So we've defined 5 of the main movement disorders, and now we're going to talk about treatment, and specifically pharmacological treatment. And so I liked this graphic so that you can see that, so for all symptoms, this is just like kind of your summary one, right? There are many different causes for movement disorders, and the different treatments are either, depending on whether it's not enough movement or it's too much movement, you're either going to raise dopamine and lower acetylcholine if it's hypokinetic, which means lower movement, and then you're going to decrease dopamine if it's hyperkinetic or there's too much movement. So when we look at these hypokinetic ones with the freezing, akinesia, which just means no movement, bradykinesia, which means odd movement, and then rigidity, things like just not being able to move but with stiffness. The treatments for those are going to be anticholinergic, so things that prevent the signaling of acetylcholine, dopaminergic, which increases the signaling of dopamine, and this DBS here stands for deep brain stimulation. So if you can find the region where the deficit is, then if you can stimulate that area, then you may see increased movement. And that actually works well for Parkinson's disease for a period of time. And then the neuronal cell death just keeps continuing, and then at that point there aren't enough neurons to stimulate. And so when you get into these mixed symptoms where you've got some tremor, you've got dystonia, some of that restless leg syndrome, there's more of a mix of things to use, right? So up here, mainly anticholinergics and dopaminergics. But down here, you're starting to get into some of the gabapentin, things that are, and propranolol, which is also affects GABA signaling, gabapentin down here again, and benzodiazepines, which also affect GABA signaling. So in the mix, it's more of a, well, let's try something a little bit of both, right? We'll increase overall signaling with gabapentin, and we will increase dopaminergic signaling with some of the dopaminergics. But then when you get into the hyperkinetic, when there is too much movement, one thing that you'll notice is that, or you may make the connection, that the neuroleptics that we talked about, which are used to treat schizophrenia, right? And schizophrenia means too much or too much dopamine. And these hyperkinetic means too much movement, which there might also be too much dopamine in these types of disorders as well. So you'll notice that some of those neuroleptics are brought back, not treating psychosis, but treating movement disorders. And then benzodiazepines, which are used to treat anxiety, because they affect GABA signaling, because when you're hyperkinetic, right, that too much movement, you need to slow it down. So you're preventing dopamine signaling and you are increasing GABA signaling to inhibit specific areas of the brain. So that's just a good summary, and classifying, okay, if you have not enough movement, we're going to use these types of treatments. And if you have too much movement, we're going to kind of flip it and do the opposite treatment. And so in general, one of the things that people use to treat movement disorders are those benzodiazepines, and that is that GABA A receptor activation. So one thing you might want to add in there is that it's going to increase the inhibition, so less activity. Another thing that people are using is Botox, so botulinum toxin for dystonias, because that's going to release or block the release of acetylcholine that is at the neuromuscular junction, released onto the muscles, activating the nicotinic acetylcholine receptors. And that's, if you're blocking that, you're going to prevent that excess muscle contraction. So for general movement disorders, benzodiazepines decrease overall function by activating GABA receptors. And then botulinum toxin which is going to specifically block acetylcholine, and so you don't get the uncontrolled muscle contraction. And then specifically looking at Parkinson's disease, the goal is to increase dopamine and acetylcholine. So one of the things is that we can use L-DOPA, which is a precursor to dopamine that can cross the blood-brain barrier. So L-DOPA then gets converted into dopamine in the brain, and then that dopamine is able to increase the motor activity. Another way to do it is to use dopamine receptor agonists. So again, opposite from those neuroleptics used to treat serotonin, where those were dopamine receptor antagonists. Now you need more dopamine activity to get the increased movement, and so you're going to activate those dopamine receptors. And I apologize, I realized there was a typo there. So it actually should be to decrease acetylcholine. And that is really just to prevent the excess movement when it's not necessary. So increasing dopamine to help with the control of movement, and to decrease acetylcholine to help control the uncontrolled movement. And there are more things that we can do. So one of the things, we mentioned the L-DOPA, which we can put in, and then that gets converted to dopamine. And when we add levodopa, we can also add these two enzymes that are going to inhibit the conversion of levodopa to dopamine until it gets to the brain. So carbidopa and benserazide are going to basically prevent the peripheral conversion to dopamine, so that the levodopa, more of the levodopa, makes it to the brain, so that then once it gets to the brain, then it can be converted to dopamine. So these two are just helpers in order to help the levodopa stay levodopa long enough to cross the blood-brain barrier and then be converted to dopamine in the brain. And one of the other ways we can increase the activity of dopamine is by using dopamine agonists. So all of these, apomorphine, rotigotine, and as you can try to pronounce these if you would like, but they're all dopamine agonists. So we have many possible drugs that are going to increase the activity of dopamine at the synapse. And amantadine actually acts as a dopamine reuptake inhibitor. So these ones up here are all activating dopamine receptors, but amantadine is functioning a little bit differently in preventing the reuptake of dopamine. And then one of the ones that we've seen before are selegiline. I'm not sure if we came up with razagiline, but they do the same thing. So these two are monoamine oxidase inhibitors, or MAOIs. And when we talked about that in terms of depression, right, it's going to keep serotonin and norepinephrine and dopamine in the synapse longer because the monoamine oxidase normally breaks them down. But these are going to inhibit that breakdown process so that the dopamine hangs around longer. The alternative to that, there is another enzyme that breaks down dopamine, that's COMT, and then these two drugs are going to prevent the activity of this enzyme. So there are multiple options to increase the amount of dopamine in the brains or in specific areas, specifically the substantia nigra for individuals who are experiencing Parkinson's disease. We can increase the precursor so that there's more of it to be made. We can activate the receptors, we can prevent the reuptake, and we can prevent the breakdown of the dopamine as well. And if we look at the specifics for all of these, right, so you have all the different drugs that are listed, their activity and what they are doing, and then how do you take it? Is it a tablet? Is it easily dissolved? Most of them are tablets. One of them is an injection. But then the thing to really look at is the side effects. And so there's a lot of potential negative side effects for these drugs. And is someone going to continue to want to take them if they aren't feeling well all the time, but they're able to move, they're able to think a little bit better? So that's one of the things, is what is the right drug cocktail for an individual based on what benefits the drug is doing and what side effects they are experiencing. And when we look at Huntington's disease, one of the issues with Huntington's disease is that it's neuronal loss across multiple different regions. Some happen to be motor, but also in the cortex and other areas, which means that there are more symptoms associated with Huntington's disease. So Parkinson's disease is relatively movement-based, and that's specifically because it's main neuronal cell death in the substantia nigra, which is important for movement. Huntington's disease, because the genetic difference leads to neuronal cell death across multiple brain regions, which means that there are going to be more varied symptoms. So there's hallucinations, delusions, and outbursts. There's depression and OCD. There are movement issues. There's mania and bipolar disorder. There's the movement issues included with dystonia, jaw clenching, and tremors. And so when you think about how you're going to treat Huntington's disease, you're going to have to treat all of those and not just the movement disorder. And so when it comes to the hallucinations, delusions, outbursts, that's often the antipsychotics or the neuroleptics, where you are going to be inhibiting those dopamine receptors. So that's with the haloperidol, chlorpromazine, and olanzapine. And then depression and OCD, we've kind of already talked about those treatments with the SSRIs. And then muscle relaxation, the benzodiazepines are activating GABA receptors. And then with mania or bipolar disorder, using some of those mood stabilizers, which we talked about a little bit, but like the lithium, valproate, and then the specific movement disorders, you'll notice that it's not as simple as treating for Parkinson's disease, which we know is just decreased dopamine neurons. And so using a more varied treatment for any of the movement or motor muscle issues. And similar to what we talked about before, the botulinum toxin is decreasing the acetylcholine binding to nicotinic acetylcholine receptors, so preventing the muscle activity. And then tetrabenazine actually does the opposite of MAOIs. So monoamine oxidase inhibitors are going to keep the neurotransmitters in the synapse. Tetrabenazine functions in a slightly different way than anything we've talked about before. So normally dopamine gets in the vesicle and then it's released by the action potential. But what tetrabenazine does is it's going to block this transporter that allows the dopamine to get into the vesicle. So it blocks it so that now there's no dopamine in the vesicle to be released. So opposite of what an MAOI does in preventing the breakdown of the neurotransmitter, this is specifically going to prevent dopamine from getting into the vesicle so it can't be released. And we'll pause here and continue with our remaining 3 movement disorders in the next video.